do this, I would do your quick Beighton scale. Look at their signs of hypermobility. Because generally those folks are going to have joint hypermobility, most of them. So just be aware and proceed with caution.
Yeah. So just simply, have we assessed the patellar mobility in any other, have we wiggled that patella around a little bit?
Well, yeah, maybe a little bit last year.
So what's the resting position of the patellofemoral joint? It's different than tibiofemoral. It's about 5 degrees flexion, right? Okay, so you flex the knee just slightly, all right? In his case, he's about 5 degrees, but you flex the knee just slightly, and a towel might be good, or a sheet, or something like that, just to fold it up. This is a nice clean, it's never been used. Okay, so, all right, let's put a little more. Okay, so flex a little bit. And I just want to, this is just an assessment of patellar mobility. So you just take the patella with your, I like taking my thumbs, and glide it medially. That's usually pretty safe to do, okay? Because typically you rarely dislocate medially. And you want to get a feel for how well that patella moves. And what I'd start with is just imagine the patella just sort of flat on the femur there, and you're just gliding it, you're translating it straight across. You're not trying to tilt it or rotate it or anything. So that's a medial glide, that's a lateral glide. Be careful with the lateral glide. And just get a feel for how that patella moves side to side. And then up and down. And the up and down is kind of like a tic-tac. So you grab your finger at the bottom of the patella, at the pole, at the apex, and then your other finger at the top. And I'm just doing this. I'm maintaining contact with the patella with both, but I'm just sort of letting up when I'm pushing superiorly with my top hand, my cephalus finger, and I'm pushing with my bottom hand. And the patella should move about half its distance normally in each of those directions. When you push down, you might feel it grind or crick or creak a little bit. And that's pretty typical after we get over 20. And you're 26, right? So, but you'll get a little grinding and crunching. That's not necessarily any big deal. So that's just the superior, inferior, medial, and lateral. And you want to compare that to the other side and see, but be very careful with the, when you're pushing laterally with that, okay? So that's just to assess the mobility, and oftentimes that patellofemoral mobility is significant with knee pain, with like return to squatting. They can squat down when they come back up, it hurts. And so it could be a pulley issue where that patella is getting hung up on something, and oftentimes you'll find there's a limitation in patellar mobility, especially inferior glide with extension and superior glide with flexion. And you move that patella in different directions and it helps. So the assessment becomes the treatment. If it's a little stiff inferiorly and I notice that he's having pain going from flexion to extension, I might do an inferior glide, and we'll do this with the Kaltenborn techniques, but you can take your hand, put it along the thigh, and you just push inferiorly and glide it. You can do a sustained stretch or mobilization, but that's the assessment there. And you could go into whole 3-day courses on how the patella moves and all that stuff, but that's the main thing, and I want you to guys feel that before we do this next test. This next test is an attempt to dislocate the patella laterally. Okay, so if you know that this person's going to dislocate, don't do this test on them, okay? But you want to put them, in this case, in 30 degrees of flexion, okay? And you push the patella laterally. And it's an apprehension test. So just like when we did it in the shoulder, you might see him, that funny guy go, you know, like that. So you look at their face to see if that's bugging them. But typically, if it's getting ready to dislocate, unless they're comfortable with their dislocations, and some people after a while, they're so used to it that, oh yeah, that's fine, they push it back in. Your quad will contract to protect it. So you'll pull it over into a glide, and all of a sudden the patella will move quickly medially as the patient contracts their quad to protect it from being hurt, okay? And there's some references that suggest you need to push it inferiorly and laterally too, but the true test is just lateral movement of the patella. And I like just grabbing the medial side with my fingers and pulling it toward me.
This is known as Fairbanks,
Fairbanks.
or the apprehension test.
Yeah, Fairbanks apprehension test. It's on page 802, sorry.
There's a picture of it, figure 1230. And this is the apprehension test. Fairbanks or apprehension.
Okay, you want to do one more and then practice all three? Okay, good. So those are the plica and the patellar dislocation test for patellar. The Noble compression test is on page 803, and it's more to confirm iliotibial band friction syndrome. And essentially, you place pressure on the lateral femoral condyle, where those fibers of the iliotibial band coming into play. The knee is flexed at about 90 degrees, okay? And that's typically where the friction syndrome happens. It doesn't happen on Gerdy's tubercle. It happens over the lateral femoral condyle. And when you guys are palpating this, you can feel where the lateral tibial condyle is, where Gerdy's tubercle is. And if you bring your thumb up to the joint line and pass it, you'll feel that your thumb will be projected more laterally, because that lateral condyle is more lateral relative to the tibia. And so the iliotibial band has to come down anteriorly, like Dr. Brodsky was saying, in full extension. It goes over that condyle and then has to project medially again to attach into the tubercle. So where it's pooching out there on that bony area is where the friction happens. Okay? So you place your thumb over that, I would say, just, huh? Okay.
So they can see where your thumb is. Where
So-
you're pressing.
What I do is I just run my thumb from the tibial tuberosity up, and where my thumb projects more laterally, that's where I place it. Okay? And then you just bring it into extension, and as the tibia starts to move anterior, the fibers start to pull across that. The iliotibial band fibers are posterior here. They come up toward and over the lateral condyle at about 30 degrees. And there was a little, that was your kneecap? Okay. And then there's, that friction happens. So we're creating friction by having our thumb over where we suppose the friction is going to happen in real life when their IT band is contracting, which is about 30 degrees. And if they confirm, yeah, that's the spot, that's the pain I have when I run, that's it, then that's positive for iliotibial band syndrome at the knee.
Global compression test for iliotibial band tendonitis.
Okay? So do the plica test, the lateral dislocation test,
Just one,
and
and then Noble. But one thing before you get up, you can also do this. I think it's also good some kind of recitation to do it actively, while you just hold their foot to see if they get that same sensation. So compress it, you still compress it, and then just kind of ask them.
straighten your knee out. There you go.
Sometimes that'll elicit it, because that'll load it more as they use the quadriceps to extend. So just try it both ways. You do it passively, like Paul showed, and then ask them to do it actively as well.